first time, I think we are doing a 3 days workshop, and we are doing a second day of inauguration. The series of workshop on the basal implantology, and we have two eminent speakers. I think they have done the excellent live surgeries where the postgraduates have been benefited, and the registered delegates who has been experienced the value of the basal implantology and their clinical concern and their aspects. And Dr. Surender and Dr. Rajesh have done an excellent job, and I think you have seen the video the first day what the workshop has been done, and definitely all the students who have been registered got benefited. On this occasion, the first time in the NIMS University, there is amalgamation of the multiple programs, and we started, and on this gathering, Dr. Ajit, who is the principal of physiotherapy, who accepted our invitation, because I know that every principal has got their own busy schedule since the morning 9 o'clock it starts. So in spite of that, they accepted an invitation with a short notice and be here. I welcome you, sir, and thank you very much for accepting the invitation. So, and there are other faculty members who have been traveled all the way and be a part of our program. I welcome you, all the faculty who have been there, and I welcome the Mr. Seshu Kumar, who is a owner of the GS company, and he has been traveled from Hyderabad yesterday to be a part of this program. So I welcome you, sir, on this occasion, and all the faculty members and the students, registered delegates who is be a part of this program. Thank you so much.
Thank you, sir, for your wise words. Now I request and invite Dr. Ajit, sir, to please come and enlighten us with few words.
Good morning. First of all, I thanks to Dr. Sunil and team for inviting me and giving me this privilege to be here. And frankly speaking, today's gift, I want to appreciate you guys giving us a plant, and definitely I'm a plant lover person. Okay. And the next next मैं आपको एक बात बताना चाहूँगा कि I'm the alumni of SDM College Dharwad. Since 2003, I'm from 2000 batch. 2003 से लेके 2005 तक मैं धारवाड़ में था. वहाँ पे हमारा जो फिजियोथेरेपी का कोलैबोरेशन रहता था डेंटल के साथ में, क्योंकि कहीं पे भी बॉडी में टिश्यू आएगा, and if you will cut, you may mark any kind of incision that may be in the inside or outside of your oral cavity, definitely the role of physiotherapy will start from the day one only. So really, I am also interested कि in case in future also I love to collaborate with any kind of other program. So I won't take much time. So I just promote all the students whoever participated in today's workshop. Just learn from the best and be the best. Thank you.
Thank you, sir. We'll definitely look forward to collaborate with you in future. Now I request Dr. Saini, sir, to please come on stage and share his thoughts.
Respected Principal Mother, faculty members and dear students. सबसे पहले तो मैं प्रिंसिपल महोदय को और आपके फैकल्टी मेंबर्स को आभार व्यक्त करना चाहता हूं उनका कि आपने हमारे को इनवाइट किया और आप सबसे मिलने का एक चांस हमारे को प्रोवाइड किया। वैसे तो हमारे को डॉक्टर साहब ने पहले ही इसकी इंटीमेशन दे दी थी, पर कुछ बिजी शेड्यूल और यहाँ के वर्क जो आप जानते हो, इसके कारण से हम आपके साथ एक्टिव पार्टिसिपेशन नहीं कर पाए। अदरवाइज हमारी ये पूरी ये हार्दिक इच्छा थी कि नर्सिंग स्टूडेंट्स भी और वहाँ की फैकल्टी भी इसमें एक्टिव पार्टिसिपेशन करें। और हमने देखा कुछ चेंज के लिए भी सर ने कहा था कि अपन कोलैबोरेशन के प्रोग्राम करेंगे, पर चलो कोई बात नहीं, हम कर नहीं पाए आपके साथ। नेक्स्ट टाइम हम जरूर करेंगे। जहाँ तक मैं सोच रहा हूँ कि इस प्रकार का इनिशिएशन सर ने यदि लिया है और ये ऑर्गेनाइज कराया है तो रियली ये काबिल तारीफ है। मैं ज़्यादा इस डेंटल के बारे में नहीं जानता हूँ, पर भी इनिशियली काफ़ी लंबे अरसे से मैं यहाँ रहा हूँ कि इसमें काफ़ी मेरा इंटरेस्ट रहा है। और ये कहो कि नर्सिंग फील्ड में तो मैं रहा हूँ, जबकि मेरा इंटरेस्ट बीडीएस में ही है। और इसी इंटरेस्ट को देखते हुए कुछ पर्सनल मैं आपसे शेयर करूं कि जब हम ट्रेनिंग में थे तभी मैंने एक हॉस्पिटल एस्टेब्लिश कर लिया था, एक छोटा सा क्लिनिक यहाँ से रिंगस कस्बा है उसके अंदर, काफ़ी दिन श्याम डेंटल हॉस्पिटल के नाम से। तो वो चला, उसके बाद में पीजी वगैरह पीएचडी वगैरह की स्टडी में बिजी रहे, उसको छोड़ा। और एट प्रेजेंट भी हमने एक छोटा सा क्लिनिक एस्टेब्लिश कर रखा है जयपुर के अंदर, श्री राम डेंटल डायग्नोस्टिक सेंटर। और करीबन 8 चेयर अभी एट प्रेजेंट में रनिंग में है। और आप शायद जानते होंगे, सभी आप डेंटल स्टूडेंट्स हैं, कि हमारे क्लिनिक का नाम शायद जयपुर में 3rd पोजीशन पर है। NABH भी है हमारे पास, उसके साथ CGHS, जो भी अपने जो स्कीम्स हैं वो सारी स्कीम्स उसमें चल रही हैं। और अच्छी OPD है, करीबन 90 की OPD पर डे के हिसाब से है। सुबह मॉर्निंग से इवनिंग तक आप कभी विजिट करो, आके देखोगे कि 8 चेयर हमारे रेगुलर चल रही हैं और 8 ही डॉक्टर हैं। और मॉर्निंग से इवनिंग तक लैब वगैरह ईच एंड एवरीथिंग कभी आप देखोगे। रेस्पेक्टेड सर से भी मैंने कई बार रिक्वेस्ट किया, विजिट करो एक बार। CGHS वगैरह सारी स्कीम्स अपने पास चल रही है। तो मेरा अभी भी पूरा इंटरेस्ट डेंटल क्लिनिक में ही है। तो मैं तो हाँ मानता हूँ कि भाई मेडिकल से पहले ये स्ट्रीम होनी चाहिए थी, MBBS से पहले, बिकॉज ऑफ हम जहाँ तक समझ रहे हैं कि मान लो कोई पेन होता है, वॉमिटिंग होती है, फीवर आता है, जो भी है नॉर्मल, घर में सभी ट्रीटमेंट अवेलेबल होता है। यदि फीवर आता है एंटीबायोटिक ले लो साहब, एनाल्जेसिक ले लो साहब, जो भी है, एंटी डायलिसिस स्पास्मोटिक जो भी ले लो, उससे ठीक हो जाता है पैसा। पर आप वाला जो काम है, बेटे के दर्द होता है, पेन होता है, चलो हॉस्पिटल। आपके खुद के किसी के पेन होता है, फैमिली मेंबर्स के पेन होता है, बिना डॉक्टर्स की कंसल्टेशन ठीक नहीं होता। अब उसमें क्या इन्फ्लेमेशन है, एक्सटेंशन है, या फिर आपको वो और कोई ट्रीटमेंट करना पड़ता है। तो मैं तो इसको प्रायोरिटी MBBS से भी पहले देना चाहूँगा कि वास्तव में ये कोर्स होना चाहिए और आगे बढ़ना चाहिए। इसके लिए सर ने ये कॉन्फ्रेंस, ये वर्कशॉप ऑर्गेनाइज की है। बहुत बहुत धन्यवाद, और हम आगे से भी आपके साथ जुड़े रहेंगे।
Thank you, sir, and we are thrilled to know about your love for dentistry. We look forward to collaborate with you in future. Now I request Dr. Mahen sir to please come on stage and share his valuable insights.
गुड मॉर्निंग ऑल ऑफ यू। सबसे पहले तो मैं धन्यवाद देना चाहूँगा सुनील सर का कि हमें इनवाइट करके और यहाँ पे बुलाया और इतनी अच्छी एक वर्कशॉप ऑर्गेनाइज की। तो हम चाहते हैं कि निम्स में सभी कॉलेजेस जैसा ऑर्गेनाइज करें और इन फ्यूचर में निम्स का नाम रोशन करें। और डेंटल में जो ये इम्प्लांट की वर्कशॉप की है, ये स्टूडेंट्स के लिए बहुत ही बेनिफिट रहेगी।
इनवाइट किया, आप लोगों से मिलने का मौका दिया। बहुत ज़्यादा हमारा मतलब टच नहीं है डेंटल से, लेकिन एक चीज़ है, होटल मैनेजमेंट में फूड, और फूड विदाउट डेंटल हेल्प चल ही नहीं सकता।
सर आप फूड नहीं देंगे तो केरिस कैसे होगी?
सो एक चीज़ जो मैंने नोटिस किया है वो है ओरल हाइजीन। अवेयरनेस फॉर ओरल हाइजीन इज वेरी लेस इन इंडिया। पीपल आर नॉट गोइंग टू डेंटिस्ट अनटिल एंड अनलेस उनके कुछ पेन होगा या कुछ टीथ में प्रॉब्लम होगी, तब तक उससे पहले जाते ही नहीं है। और ब्रश भी ट्वाइस नहीं करते, एक ही बार करते हैं। सो अवेयरनेस फॉर दिस पर्पस, अगर आप लोग अवेयर करें लोगों को ओरल हाइजीन के लिए, तो मैं समझता हूँ आपकी फील्ड में बहुत स्कोप है। और डेफिनेटली सारा काम दांतों से ही चलता है। अगर आपके डेंटल स्ट्रक्चर ठीक नहीं है या है ही नहीं, तो सरवाइव करना मुश्किल है, पॉसिबल ही नहीं है। So it is very important. I am thankful to Dr. Sunil inviting me for this beautiful conference, and I am inviting you for tomorrow's event. We are organizing a mega culinary challenge in the campus only, in the cricket ground. 43 teams from different university and colleges are participating from Jaipur and the other states also. It's a national conference kind of thing. 7 celebrity chefs and senior people from hospitality industry are also coming to share their views, and jury of that event. So I am inviting you all, including your whole team and the students and the principals, sir, to please come and see a different kind of event. Flavorful or tasteful event in the NIMS University, right? So thank you Sunil sir for inviting me. Thank you so much.
Thank you, sir, for your words. And with our whole heart, we accept your invitation. Definitely, all our students and all the faculty members will be there. Thank you. Now I request the gathering to remain seated while the dignitaries leave the stage. Thank you. We'll continue with the program.
Thank you one and all.
वो तो सुबह से निकल
थैंक यू। साउंड आ रहा है क्या? नहीं अभी कनेक्ट मत करना, मैं बोलता हूँ आपको। डोंट कनेक्ट या सेट, मैं बोलता हूँ आपको। माइक चल रहा है ना? हाँ मॉडर्न 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 हो रहा है मॉडर्न. कनेक्शन देने के लिए बोलो ना. लेट हिम कनेक्ट. Yes. So, hi, I'm Dr. Surendranath, and today I'm going to present some of the cases of full mouth rehabilitations, and that too, many are special cases, and many cases are done with no bone conditions and in the conditions where the other clinicians have rejected them, and most of these are cases done by me as a consultant. Okay, so instead of making you bored with the anatomical and occlusion and all, I'm simply showing you the cases, and after these cases we will go for the processes part, and the process, how we actually give the process and how is process important in the long-term success of any implants, basal implants or all-on-4. So I came from a background of conventional implants after placing around 2,500 implants of dentium, ostium, Edin, Norris. After placing some 150 full mouth implants all-on-4s, I came to this basal implantology because I am rejecting at least 3 to 4 cases per month because I am finding no bone, or sometimes I am finding bone but I am loading them too far late, 6 months, 7 months, because of the quality of the bone, especially in females. Okay, so yesterday also the case, the bone was not good. Matlab, it is osteoporotic. Okay, so this is a case. The patient's age is 28 years and he never had teeth in his mouth since birth. So the trauma it caused, you can see all the teeth are impacted. 2 wisdom teeth left in, and everything, every other teeth has been removed. So in this case, some basal implantologist has attempted, and he has punctured many holes throughout the maxilla, including the pterygoids. He was not able to engage the nasal floor properly. You can see in the picture number 4. In picture number 3, you can appreciate the post-op OPG after the extractions of the impacted teeth. So at this stage, patient was so much traumatized. He is 28 without teeth. He dropped out from the college, +1, +2. He didn't go to the college because he is not having teeth. So I didn't took this case in a psychological manner, but afterwards I'll tell you the entire story. So I went there, placed a zygoma, double pterygoid, And here you can see this is a triple pterygoid. Triple pterygoid because I avoid zygoma in as many cases as possible. The reason being, zygoma in local anesthesia especially, so there is a chance of oculocardiac reflex always. So people do it regularly, but I insist that if you are forced to do a zygoma in a local anesthesia, you go with a IV placed prior to the procedure. So a IV line pink cannula can be placed prior to the procedure, and you keep your atropine and adrenaline ready. So because 0.6 ml of atropine is always injected before the general anesthesia, because there is always a chance of oculocardial or vasovagal reflex. So how do you know that patient is having this oculocardiac reflex? This oculocardiac reflex is very, very slow in onset. Matlab it doesn't hit right away. So you'll be doing your procedure, slowly the heart rate of the patient will go down, and that's why it's very mandatory to have a monitor in your clinic and a IV line ready with the emergency kit ready when you are going for zygomas, especially zygomas. Other things, nothing will happen with basal other than the zygoma. Even in the conventional, that's why they prefer GA for the zygoma cases, because when the heart rate is going down, the BP is going down, the anesthetist will not even tell you, but she will inject atropine silently. So that's the best way. Do your cases of zygoma and GA. If you are forced to do in LA in such cases, go with IV line prior to the surgery itself. Yeah. So, and again in the lower arch, you can see two on the both sides, third and fourth quadrant are engaged into the mylohyoid ridge, and 4 are tilted in the Allen 4 fashion, and that's it. So, I'll show you so what kind of effect that this treatment gives on a patient is, so you can see this is a young male, 28 years, and now we have completed 2 years follow-up, but you can see the patient truly edentulous from the beginning. He has only one dream, that he should have teeth, not for function of mastication, but for his not for aesthetic, for his emotional well-being. So the trauma that he got through is what I realized after he came to invite me for the marriage, for his marriage. Right after 2 years of placing this, he got married. And also he stopped his studies at +1 level, and his father gave him some money, and he जैसे किराना shop होता है ना छोटा सा, वैसा he set up something like that. And now after marriage, he again invited me within 3 months for his supermarket opening. So what happens in life is that you will miss something, only you will recognize it after you miss it yourself. So I am not thinking about this case in such great terms, because it's just another case where everyone is rejecting, and I have done this in Bangalore. You can see yesterday someone is asking me while I was bending the implant, how much can we bend an implant? Okay, so here, अरे आ जाओ पांडे, अभिषेक पांडे, आ जाओ, कुछ अटक गया है. Enlarge कर रहा हूँ, पर हाँ, this is the zygoma. Double pterygoids, you can see the double pterygoids are looking the other way, zygoma is looking the other way. Most of the time zygoma will land in the palate, as sir said yesterday. So if you want to purchase a 60-degree angulated multi-unit abutment, you need at least 4,000 rupees. But see what happened here. It's in the palate. Now I started bending, bended. This is the 55-degree bend. So that's the strong cortical of zygoma, where you can bend it till 90 degrees, nothing will happen. Okay? If you can appreciate the sound, yeah. This is the post-op CBCT. You can see the bone. and the quality of bone. This is just a 10 into 10 FOE, 10 FOE CBCT, so that just while entering the zygoma is got, the FOEs got over. See here, you can see the mandible, how deficient mandible he has. You can also see the engagement of pterygoid. I made a separate video of this, I will show it. Yeah, this again. You can see the three implants are sitting right in the pterygoid, and you can appreciate the remaining implants are in the nasal floor, and one zygoma bended. It actually zygoma, yeah. So yesterday someone asking, should I pierce the bone and engage it? Always. Shall I pierce a cortical plate and engage it? Always. Shall I pierce the zygoma through and through and engage it? Always. So the patient will feel a pimple here. If he can do like this, he will feel the external thing which pierced out of his zygoma to here. Even I use my hand or a finger to know whether the drill has pierced. So that's how basal implantology works. And of late, even Noble Biocare has changed their protocol, and now they are telling to engage the second cortex even in the conventional implantology, if you are aware about the recent developments. Yeah. Yeah, this is the post-op CBCT. And going forward, so this is a prosthetic case. So this is like, and then the STL file will be fed to ExoCAD. In ExoCAD, a version of 3.0, that is Galway, 3.1, that is Regeika, supports a version called anatomic wax-up on a substructure scan. So that's very important for us. See what magic it does. So this is the bar, nickel chromium. So I have fitted exact fit. So then I am scanning with the intraoral scanner. So the intraoral scanner has recorded the bar so well. Now the scanners are recording the metal, ladies and gentlemen. Previously the scanner would have gone haywire when it sees metal and it asks you for a titanium oxide spray. You can also get it in the market as CAD-CAM spray. But CAD-CAM sprays are no longer necessary with the modern generation scanners. So this is the scan, 3D scan. This is the wax up which you are seeing. This is what we do as a, this concept is developed in Italy in the year 1960s and 70s, but they used to do manually called shell dentures, and now this is shell zirconium. Yes. So that is the bar substructure, that is the luting space that I have given, the red thing. This is the final zirconium, monolith ST. ST means super translucent. Monolith means it doesn't have any layering of ceramic on it, it's pure zirconia. And on the bar I am placing the zirconium crowns. So see the aesthetics. See, just her smile line. She was just not giving the mirror back to our staff again. So she is a long-term sufferer. You should experience them firsthand. Yeah, this is a common case of quad pterygoid which we do in a highly pneumatized sinuses case. Yeah, again, I will show you that later. So many people are asking me why I go so deep in a mandible. Why I do bypasses everywhere. So these are the nerve bypass 2 and 2 are the nerve bypass here. So why I am going such depths everywhere, these are the pterygoids you can see. Wherever you can engage 4 plus 4, 8 in the nasal floor, you need not go for a double pterygoid. You need single pterygoid only. You need single pterygoid only. I will explain in a later stage why it is important to master the technique of double pterygoid or a quad pterygoid, is that if you are not mastering that technique, you will be forced to do zygoma. Even in the conventional implantology. If you have a deficient bone here, you are not getting 2 or 3 nasalis. Even if you are getting 3 nasalis, you will be forced to go for a bar attached hybrid denture or bar attached removable hybrid denture, or you should go for a pterygoid implant. If you are not going for a pterygoid, if you are not comfortable with pterygoid, in conventional also, you will be forced to go to Chegoma. So this one, yeah. Why I go so deep in the during the drilling will be integrated, not osteo integrated, but it will just he is not maintaining hygiene. Even if he is a smoker, I don't accept that smoking will at least lose a single implant. No. In conventional, yes. In basal, I have seen heavy smokers, heavy tobacco eaters. Nothing will happen. As long as Dr. Stephanie Day will always show a picture if you have attended his classes anywhere. ENT surgeon was going through the endoscopy and he is finding this radar dooms on the mucosa of the nasal floor. So the radar dooms are our dooms, implant dooms, and that's the correct way to engage. So don't feel shy to engage a cortical, nothing will happen. Nothing ever will happen. Only thing is the good will happen. Even in many of the surgeries, you will always rely on the cortical bone. Never do a orthopedician relies on a trabecular bone. Never ever. If you have orthopedicians in your life, in your आपके relatives में हैं, so you can ask them. They will never ever rely on this concept called osteo integration. Yeah. So this is the case that I have done in Jodhpur. So yeah. So here there is, I went for another purpose. So then suddenly someone called me. This is a double nerve bypass. The patient is coming from Mumbai to his clinic. This is Dr. Ashok Sutar's clinic in Jodhpur. It's Jodhpur Polyclinic. Yeah. I've written there. So you can appreciate the lack of bone here, and there is pus drooling everywhere. When I removed, there was no interradicular bone itself. When I removed the tooth is like hanging. So I have removed the tooth, I have removed the granulation tissue, and yeah, this is the engagement to the cortex. That is the nerve which you are seeing in the between, highlighted in the orange color. And this is again below the mylohyoid ridge. This is the mylohyoid ridge, the slope. We have engaged. This is the buccal. This is the lingual bypass. This is the buccal bypass. And then I think this is again a video. अरे एक बंदा इधर है ना, क्या हो रहा है बार-बार? Yeah, I'm sorry that I am so unprepared for this because I had a mandibulectomy. I had to perform a mandibulectomy just before my flight, and I almost missed my flight before getting here. And every day it's like this only. So I didn't prepare so well, but I am going to show you the best. So this is the buccal and the lingual. See, you can see this is the buccal. I have perforated the cortex. You can see the threads out of the cortex just shy of the mental nerve. Yeah, can you appreciate it? These are the threads in the buccal cortex, just shy of the mental nerve. And the lingual cortex, this is the mylohyoid ridge. This is what we are speaking about from yesterday. This is the mylohyoid ridge. You should not be superior to mylohyoid ridge because of the simple reason that mylohyoid ridge is the last point till where the mandible will get resorbed. Mylohyoid ridge will never get resorbed. Sometimes the mandible buccal to the mylohyoid ridge will resorb, and mylohyoid ridge will itself be shooting up like this. In the cross section, if you see the CBCT, this is the mylohyoid ridge up and on the what we call this as on the occlusal surface, and you will have tissue or your gingiva on the mylohyoid ridge. And I have never seen a mandible getting its mylohyoid ridge resorbed. Never ever. So, and there is another golden rule that your mandibular canal is always at the level or below the level of the mylohyoid ridge. Never above it. Never ever above it. So these are the landmarks that we see thousands of mandibles and CBCTs, and then we hitting an artery or a vein. If you are going to hit an artery, you are going grossly deep into the soft tissue. So how would you know that you are impinging and violating all the rules of soft tissue? Yeah, you will always keep your finger. Your finger is at risk, not the soft tissue. Your finger will burn. Sometimes my finger will burn because of the heat of the drill. Sometimes I pierce myself. But the soft tissue बच पाएगा. ठीक है? Yeah. And also, sir, if the soft tissue gets entangled into the drill, you stop it right there, don't pull it back. You make the physio dispenser setting go on the anti-clockwise, slowly press it, go into the 20:1 ratio, not 1:1 ratio anymore. Yeah. Yeah. So this is the case, and she was surprised, and she went to Mumbai then and there. Within the next 3 days, she has given the cap. Yeah, we have went to the desert there. Okay. And again, this is the case. See, how will you rehabilitate this case? This case is done by me at Palnadu district in Andhra Pradesh. So you can see pus everywhere. There is no maxilla at all till this is the nasal floor. So nothing is there. Even in the lower quadrant, you can see nothing is perfect. So rehabilitating maxilla is like a miracle to them.
सर जो कन्वेंशनल इम्प्लांट हम करते हैं
हाँ
उसमें पेरियोडोंटाइटिस को हम बहुत ज़्यादा कंसीडर करते हैं
हाँ हाँ नहीं हम हरगिज़ नहीं कंसिडर करते. देयर इज लेना देना ही नहीं है पेरियोडोंटाइटिस और बेसल इम्प्लांटोलॉजी. कंप्रेसिव से है. दैट्स व्हाई आई नेवर यूज कंप्रेसिव. Rough surface is rough. For me, rough surface is rough surface number 1, periodontium. Rough surface number 1 attracts periodontitis. Rough surface number 2, rough surface implant or compressive implant, they will attract peri-implantitis. I never use rough surface implants in my practice. Never. Only smooth. Only basal. I will not be in oven bone at all. Unless I am placing the osteum or... Yeah, nothing will happen. Corticals are never perforated by any infection. These are the principles. You go to an orthopedician, not senior, not junior, our age. You talk to them, they will tell you the same things. If they are not engaging the second cortical, they will remove that screw and again go into a different site and engage the second cortical. Always. I will show you their x-rays of fixation. Their principles of fixation is always into the corticals. Always smooth. Yeah.
यही है फोबिया है कि वेसल में अगर कभी कोई केस रिपीट करना पड़ गया तो उसको मान लो रिट्रीव किया अपन इम्प्लांट को वापस उस जगह इम्प्लांट अपन कन्वेंशनल में लगा सकते हैं. वेसल में उसका पूरा परफेक्ट हो गया चेहरा तो.
See, I'll tell you one thing. If done properly, basal has a success rate of not 99.9%, 100%. Believe me. And if you are not following the principles, वो कोई शाहरुख खान को मूवी में देखा दर के आगे जीत है कोई क्या है वो माउंटेन ड्यू है क्या? So you should come out of it, sir. I know that I am the greatest all-on-4 placer of my time. From 2010 to 2020, I have placed at least 150 or plus all-on-4s. I can give proper mallow bridge. I have everything. I have CAD CAM lab, everything. बस छोड़ के आना पड़ा उसको. बस. I'm telling you this. These are the aesthetics. If you are still planning or you are still thinking that basal implants we can't give aesthetics, you can give proper aesthetics with proper zirconium, not hybrid. अरे कुछ भी नहीं होता है. रिट्रीव करने की जरूरत ही क्या है?
पूरा फेस तो परफेक्ट कर दिया आपने, अब क्या करें?
So then you should do one thing. You should never lose your tooth. Yeah. So these are the implants. Yeah. No, just like my friend told me. So I said, "Arey yaar, ye to बर्बादी हो गया, अभी क्या करे, बड़ा सर्जरी बढ़ेगा। तो वो बोल रहा था कि पहले इसको गुटखा नहीं खाना चाहिए, तो ये हेमी मैंडिबलेक्टमी इसलिए करना पड़ा। तो इसलिए देन यू आर सीइंग हियर ऑल द बेसल इम्प्लांट्स। दिस इज द थर्ड डे, बिलीव मी, फ्लैपलेस, स्टिचलेस, पेनलेस. And then this is the zirconium that I prepared. Zirconium always, again, I am saying if you are going for a full mouth zirconium, always give supports to your zirconium. This is very important. You will be planning it good, you will be doing the exocad good, you will be milling it good, you have a really good Roland 4-axis, 5-axis milling machine, you got it in your hand, you put it in the centering furnace, again 1550 degrees for 8 hours, you get in your hand, it will be this much only. It will shrink. So you always have this supports. This is the supports, so that because the maximum shrinkage will happen here. Yeah, will happen here only at the tail end. Give a big support here and give small supports here. Okay. So I'll show you the video. This is the zirconium residual powder which you will sandblast to remove it, which you can see here after this entering. Okay. So I'll show you. Yeah, this one. These are the supports that are mandatory for a sintering cycle. But if you are giving zirconium for 3 units or 4 units, it's not required to go for a framework. That's why we give these supports. And then afterwards, after glazing, this is the final result. Oh, I'm sorry. Yeah, this is the final result. You can see, you can appreciate the beauty, and the patient never comes back. If you are using a resin cement, no GAC at all. Resin modified GAC, no. Resin, only dual cure resin or self cure resin, your wish. Not GAC, not resin modified GAC. Yeah. Okay. This one is the only resin cement, resin luting cement. Okay. And then this is bicarticalization again. So I don't want to show you again and again, but yeah. Here there is a small point that in male, in a good male, in a healthy male jaw. So, yeah, see the bending and the advantage of bending and not using a multi-unit or an angulated abutment. So, this case, I have engaged one into the lingual cortex, one into the buccal cortex immediately after extraction. Now see. So, I have placed the ratchet. And then that's the bend, straight. And those people, then I bended that as well. But I want to tell you a secret, that those people who are already into implantology, you can relate with this. A screw, a single tooth with a screw, if it's not given as a screw retained process, screw retained metal, ceramic or zirconium, a single tooth will be shaky for the next, within the next 1 year. Have you experienced this?
Yes, sir.
Cement retained. They will be moving. So in screw retained, if you going and closing the screw channel very tight, neatly, if it gets looses after 1 year or 2 years, you will again open the composite, you will tighten it. No. That will happen, that implant head will be fractured before the patient comes, because it will be moving and he will चिक्की खा लेता है और वो फ्रैक्चर ही हो जाता है इम्प्लांट हेड, और आपका हेक्स और आपका थ्रेड, इम्प्लांट का इंटरनल थ्रेड होता है, वो भी फ्रैक्चर हो जाती है, और कभी भी आपको वो उसको ट्रेफाइन पर आपको खरीदना पड़ेगा फिर से. So have you ever removed that screw it and process and sent to any lab, any culture lab? Have you ever, after 1 or 2 years? Have you smelled the Teflon while you opening it?
Yes.
So how much bacterial load are you keeping on your implant head? What is the load of the bacteria? I can't even count. That's it. That's the thing that I am saying is aseptic connections, less number of connections, more comfort. Okay. So next, this is the case. This is again a case of failed basal. Never do basal like half-heartedly. Do it full-heartedly or remain in a conventional implantology. No problem. The cases you reject, I'll catch up. The cases somebody will reject, I'll catch up. But you will not have failures in your life. That's better. It's better to reject than to have the mark of failure. Okay. So this one, he has, this is a highly pneumatized sinus. As soon as you get your X-ray, look into the sinus, and pneumatization of sinus will happen as the age progresses. See the pneumatized sinus, even the canine has been obliterated, canine bone. Here even the canine bone has, the part of bone which is supposed to be holding the canine has been obliterated till here. If you can appreciate, if you can't appreciate, please come closer, no problem. You can like stand and see here also. So in this case, with heavily pneumatized sinus, if you are not going for pterygoid, and if you are thinking these 4 teeth will help, and these 2 implants will help with functional mastication. What you give is a compromised mastication, never a functional mastication. So what happens is, कुछ कर दिया वहाँ पे मैंने, हाँ नहीं, हाँ ठीक है फिर. तो क्या होता है, मतलब, see again this case, ladies and gentlemen, you can see the last implant is here, and if I am placing single pterygoid, I will be forced to go for a zygoma. That long span bridge is going to ruin the long-term life of this teeth. Yeah.
आपने एक पिछला केस दिखाया था जिसमें आपने नेजल फ्लोर के नीचे 8 इम्प्लांट लगाए हैं, लेकिन टेरिगोइड में आपने सिंगल इम्प्लांट लगाए हैं.
इसमें 8 नहीं लगाया, 3 4 ही लगाया.
उससे पिछले वाले में.
हाँ, उसमें जब 8 लगाएंगे तो एक काफी है.
तो मेरा कहना है कि इसमें स्क्रू फ्रैक्चर का या इम्प्लांट फ्रैक्चर का कोई चांस नहीं होता.
नहीं, कभी नहीं,
बेसल में नहीं होता.
कभी नहीं. जब हम इंसर्ट करते हैं ओवर टॉक आता है तब हो सकता है. जब हम इरेस्पॉन्सिबली बेंड कर रहे हैं तब हो सकता है, पर रनिंग में कभी नहीं.
ये 60 एनसीएम 70 एनसीएम पे अपन ने इसको
बस ज्यादा नहीं है, उससे ज्यादा नहीं जाने का. 70 is max, otherwise it breaks in your hand. यस, प्रोस्टोडोंटिस्ट अगर है तो यहाँ पे आपको मालूम है, ऊपर से कितना भी लोड पड़े वो कुछ नहीं होता है. सिरामिक अंदर से जरा भी लोड पड़ा है, पूरा सिरामिक चिप ऑफ हो जाएगा. तो दैट फ्लेक्शनल फोर्सेस विल ऑलवेज बी देयर इन ए निकल क्रोमियम restoration. Okay, so what we have do is this one we have engaged 3 and this previous implant is crisscrossing the sinus here and going and entering into the nasal floor. This is what we call first cortex, second cortex, third cortical engagement. He has done it correctly. So I have left this implant there only. And then this is the long span which I have to avoid. So I didn't place single pterygoid, but I opted for 2 pterygoids. And again, I have seen where there is a long span bridge and there is a single pterygoid. You always have this kind of thing that this pterygoid plate will leave this implant because of overload osteolysis. This is again a concept of orthopedics. So when you overload it from day 1, the load will cause the osteolysis, not the infection, not the pus, not the bacteria. The load will cause the, again, in the conventional implantology, you know the best time to remove an implant is the 2nd week, because the maximum osteoclastic activity will happen in the first 2 weeks. So that osteoclastic activity will never stop when you overload it. Okay, this is a concept of orthopedics which we have taken into our implantology. Okay, so why does overload osteolysis happen, and how do you identify it in your OPG or X-ray? Yeah.
Sir, adjacent to the threads there might be radius.
अरे वो तो है, ऑस्ट्रेलाइसिस मतलब ही हुआ है. पर वो ओवरलोड ऑस्टियोलाइसिस है, नहीं तो वो बैक्टीरिया की वजह से आया है, नहीं तो वो कुछ वहाँ पे जैसे आप ड्रिलिंग कर रहे हो ज़्यादा आरपीएम में, वहाँ पे नेक्रोसिस हो गया उस आरपीएम की वजह से, वैसे कैसे एंड द नेक्रोटिक बोन विल आल्सो बी ऑस्टियोलाइटिक फॉर द नेक्स्ट 2 or 3 weeks. Okay, so how do you identify? So when you have an infection, this implant, if this had an infection, there will be radiolucency from the in the adjacent bone also, somewhat radiolucency. But if it is pure osteolysis, you will find radiolucency, but apically there is radiolucency, and all around the radiolucent lesion, you will find a line of healthy bone which is now corticalizing. This is called reactionary osteogenesis. Okay? Yeah. So we'll proceed. This is the case where you will be forced to do zygoma. Always be careful that if your patient is 40 years or younger, or 45 years, or 50 years at least, his life expectancy is the next 30 years. So always be careful with them, because you need your system, especially that case. That young chap is just 28. He will live for 50 more years probably. And how confident you should be with your placement, because you are not giving anything temporarily. Okay, yeah. And yeah, again I'm sorry for this unprofessional presentation. Yeah, this is देखो ऐसे आते बीच में all on for मेरा 4 years ago, 5 years ago बोल के. Okay, no problem. अरे आ जाना ये क्या हो रहा है यार इस लैपटॉप में. So yes, again people are asking me about the minimum thickness of a bar. The minimum thickness of a nickel chromium bar should be 3 square mm. The minimum thickness of a nickel chromium bar should be 3 square mm. The minimum thickness of a titanium bar should be 3 square mm again. The minimum पर HT आपको तो मालूम है सफेद दिखता है, कितना भी आप कलर मारो सफेद ही दिखता है. So we are now using ST, super translucent blank. So super translucent is lesser in strength than HT. STML, super translucent multilayer zirconia, is even softer than the ST. STML is like, yeah, super translucent multilayered zirconia, ML, yes, STML. Okay. I'm sorry again. Yeah. So I want to again tell you a basic principle of prosthesis, that you always maintain the AFMP angle 0. Don't be a hero by giving cusps on the molars. Any prosthetic pieces here? Prosto pieces here? Prosto? So AFMP angle, how much do you maintain generally AFMP angle? Your plane of chamfer is 0, okay, it's taken granted. And now what is the AFMP angle when you are giving a mallow bridge on the Allen 4? Around 13 degrees on the other side. No, for you to understand, the guiding cusp. How much do you generally recommend a guiding cusp to be? Yeah, okay, no problem. Let's forget it. AFMP angle, you can Google it, and you will know that you should maintain 0 for your piece. Because if they are cusps, you should give cuspal guidance occlusion. And 4-point, you know 4-point occlusion, madam, ladies? Okay, yes. Okay, we'll go further. Yeah, no problem. We can learn anytime. अरे यार आजा आजा नीचे क्यों नहीं जा रही है अरे यहीं पे रहना यार. So yeah, these are the screw retain process given recently, but okay, that's okay. So AFMP angle, you please research and let your colleagues know about it because it's very important. I will show you this case also. This is also very important. This is a condylar fracture. Yeah. So see, you may tell one thing. You may have that question in your mind that चलो ठीक है जैसा हम बार दे रहे हैं उसके बार के ऊपर तो हम कुछ ना कुछ शेल जिरकोनिया शेल डेंचर तो बना देंगे एनाटॉमिक वैक्सअप में, पर जब वेल्डिंग करेंगे तो कैसा करें. ओके, सो दिस इज अ वेल्डेड sectional implant. So I am giving the margin. See the margin. Will exocad allow you to do such blasphemy? To give such disoriented margin? No, it will never. But that will be tweaked when you opt for a digitally wax-upped substructure. This is the mode which is available on exocad 3.0 or higher. Yeah. So it's just a blasphemy. That's the margin line. These are the 3 units of zirconia. See, this is a 3D printed model. You can see the same. See the fit. This is the zirconia 3D printed. And in the mouth, there's a bar. There are implants. 3rd day, immediate loading. That's it. And again, the cement should be resin cement, not GIC. Yeah, thank you. This is the X-ray. Yeah. Okay. Then I would like to master the art of making denture, क्योंकि that's how you can master the full mouth rehabilitation cases. Okay. So everyone, endo, prosto, no problem. Everyone should master the art of making a denture. Proper video recording. I again asked you, what is the plane of chamfer? Your first year PGs? So no problem, leave it. Okay. So this is a welded bar. Again quad pterygoid. I was only able to place 5 implants here, 1 in the sinus floor. So I don't consider this as an implant at all. Again, sinus floor is an unstable cortex. Sinus can pneumatize any time. If with pneumatization the cortex comes down, it will spare your implant. If your implant is healthy, it will make a mountain in the sinus floor, because it will spare your implant threads and then it will come like this. Okay. So this one, I want to show you that this is the 3rd cortical engagement here. You can see this is the first cortex pierced, 2nd cortex into the sinus, travel through the sinus into the nasal floor. This is the 3rd cortex, right? So this is important because this is unreliable. Many times it leaves you. Yeah. Okay. Sinus floor is an unstable cortex. Yeah, that's it. For these 2-stage implants, it will not leave. Even if the sinus is pneumatizing, the 2-stage implant will have its own mounting. Okay, that's the advantage of 2-stage implant. Yeah. I should also say the advantage. Okay. So unstable cortex, don't at all. Yeah, this was me in Nagaland doing these cases. This is a normal sectional case. Okay, no problem. Yeah, I want to show you this case. 5 mm of maxilla, 5 mm of premaxilla, 5 mm, and this, if you push your finger hard, you will land in the sinus. here you can see paper thin cortical. That's why I always say sinus, the floor of the sinus is unreliable cortical. Okay, but it is the easy cortical to engage. It will be around 12 or 13 mm in depth. Okay, see this case again. I have engaged 4 implants here. That's why single pterygoid here. 3 here. That's why double pterygoid here. Very mandatory, very important. Okay, and I also want to mention another thing, that if you really are into implantology, any implantology, please do note that bisphosphonate treatment is very good, very good, very good. Don't, I am relieved. Okay, okay. Going down or up, yeah, this is again a case. So these are the natural cases that we are seeing, general cases. Yeah, this again, this I want to show you. This is a through and through buccal bypass. When do you do this? It's opening up. Your finger will be there, it's opening up. And that's a contraindication that will cause loosening of implant anyway. So don't cheat yourself that it's going to stay because you are stabilizing, no, nothing. So I always recommend a buccal bypass only when your lingual cortical engagement is compromised. Don't go for a buccal bypass then and now. It's very dangerous. Your nerve is always buccally placed, so you will always injure it. Okay, go for lingual, always lingual, always lingual. And in the cases like this, where you can see here itself, the mylohyoid is here itself. You can see on the crust there is mylohyoid. You can see the white line on the crust there is mylohyoid. If there is a crust, the crust itself is made of mylohyoid, I would recommend a buccal bypass, and that too cautiously. Yeah. Again, I will stop at cases which are worth watching. This is again these cases will get you a lot of craze among your colleagues, that they will be calling you from all over. अरे यार सिंगल टूथ है, अभी एक्सट्रैक्ट किया, पेशेंट इम्प्लांट मांग रही है, अभी यूएसए जाने वाली है, नहीं तो यूके जाने वाली है, अभी मैं छोड़ नहीं सकता पेशेंट को, तो आ जा आके एक बक्कल एक लिंगुअल बाईपास करो और लोड इट इमीडिएटली. सी दिस इज द केस ऑफ, दिस इज इनटू द mylohyoid. Yes, this is the buccal bypass. You can see buccal cortex pierce. Sorry sir, sorry, 1 minute. This is the bar stabilizing the 2 implants, and that's the post-op X-ray. Yes, that's it. Yes sir, please. हाँ, उसके ऊपर जिरकोनिया दाद दिया था सर. See, all-on-4. This is again an all-on-4 which I have done 8 years back. The entire hybrid denture has been worn off because of our masticatory function. And believe me, after 5 or 6 years or 7 years, if the hybrid denture, your acrylic hybrid, if it worns off, the patient will be happy. The patient will not be angry on you. Believe me, because she has used it. अरे नया गाड़ी ले लिया और इतना घुमा लिया कि टायर घस गए, तो आप बुरा क्यों मानोगे? यार इंजन तो सही है, इंजन तो सही है. So see, how can you do this in a minimalistic way, without opening the bar, without sending to the lab, without such costly affair of having a zirconia? See, this is the easiest kind of process that you can do on a bar. The bar is your playground. You can play any way you want if you master the technique of wax up. आ जाना यार. ये क्या हो रहा है? हाँ, ठीक है, ठीक है, ठीक है. फिर क्या हुआ? This is, I am doing the Sheffield test. Yes. Can you please explain me what is Sheffield test of passivity?
1:2 test.
Very good. Professor. This is the cardinal test of all-on-4. If you are doing all-on-4, Sheffield test should be positive. Otherwise, you are loading your implant in a bad way that it will fracture. Okay. Sheffield test. I am pressing the bar again and again by tightening one screw to see if the Sheffield test of passivity is violated or not. Yes. I am working on the CAD CAM system. This is the milling machine Roland, DG shape. And this is the support again. Have you missed it or have you seen it? Yeah, very good. Then that's it. So I am cutting the support. This is the raw zirconia. I am adding gingiva to it. This is the bar, ghusa diya andar. So see the final result. That's the pre-op. This is the bar and the zirconium. And this is the post-op. See the beauty of the modern day prosthesis is you will not get your black coat white. It's like stainless prosthodontics. It's like bloodless implantology, stainless prosthodontics. अरे अब तो रुकेंगे नहीं छोड़ो. तो अभी ठीक है. And this is again, I have explained, yeah, this is again an interesting case that I have done in Hyderabad. So this is a failed all-on 5. My friend who, so let's leave him. This is the case that I have done in Hyderabad. This is a failed all-on 5. I have removed and placed basal. And you will get to see many cases if you are going to practice basal implantology. You are the first in the list of their call list. Matlab, whenever something happens, they'll call you. Okay. हाँ देखेंगे जी. Yeah, this one. I want to tell you the super thing about on-substructure scan, but pure wax up in exocad. Rijeka, this is the Rijeka version. So I will show you how beautifully you can make. I am sorry that this is very, very small. It is coming very small. This is what we call it as zero line of camphor. Okay, plane of camphor, sorry. So these are the abutments, lower teeth, upper teeth. फिर अटक गया है क्या? या नेट क्या हुआ? ठीक है, लास्ट 2-3 वेल्डिंग पे दिखा के छोड़ देता हूँ बस. So this can be done. Pure zirconium monolith, beautiful process can be given on basal implants. Yes. See, this video can help you a lot if you are planning to do really good work in basal implantology. अरे कुछ तो करो उसको. ये एक वीडियो दिखाता हूँ बस, उसके बाद आपको अगर 2-3 प्रोसेस वीडियो देखना है तो देखना है तो दिखाता हूँ. उसके बाद हम वेल्डेड बार्स और उसके ऊपर शेल डेंचर. कौन सा शेल डेंचर? नॉट दिस एक्सोकैड बट योर रगेड शेल डेंचर वेयर योर ब्लैक कोट टर्न्स व्हाइट. आई विल शो दैट आल्सो. दैट्स अ चीपर अल्टरनेटिव. That's the most available alternative. Yes? Okay. Your internet connection. कुछ तो चला गया इसमें. हाँ, ये देखिए. I have placed implants, 5 implants into the nasal floor, always to the nasal floor. This is the scan, upper implants. 5 implants, lower implants, 2 implants, and 5 to 7 implants. See, I am placing the crowns. See the fit, see the perfection of the crowns. This is the new age technology. See the X-ray, you can appreciate the nasal floor engagement. The bone is good, but I didn't stop here or here. You will be fooled. They will move. Yeah. No, I don't give bar in 90% of the cases. Even in the previous case, I was showing pure exocad of pure anatomic wax up without a substructure. That's what I am saying. I will play if the internet is restored. I will see the zirconium with a cross section of 12 square mm is itself a bar. Less than 12 square mm, you are going to see that patient again. Metal ceramic 3 square mm. 3 square mm is no. You can give direct metal ceramic on the zircon. एक्सपर्ट बन गया सर तो अभी या नो प्रॉब्लम दिस इज द पोस्ट ऑफ एक्सरे या क्या करे इसे हो गया स्कैन बॉडी भी है आपको चाहिए तो अभी सर ये बात हो रहा है कि जब स्कैन बॉडीज हमको तब चाहिए जब हमारा स्कैनर आइडेंटिफाई नहीं कर पा रहा है मेटल ऑब्जेक्ट को yes in the case matlab the radiation oncologist sisters pregnancy delivery there in US within the next 15 days she got visa suddenly so what I have done 2 into the base 2 into the mylohide this thing she will never come back. No peri-implantitis, no stitches, 3-day loading. This is direct metal ceramic caps on the no bar, madam. Only implants, caps. Yeah, this route is saved, madam. Measure to the mental foramen, yes. Here is the mental. You can come close, madam. No problem. Here is the mental foramen. You can see and appreciate. Yeah. This comes buccally, this goes lingually, it's like a tent. जब भी आपके घर में कोई आके टेंट बनाता है एक तो टेढ़ा ही डालता है ऐसा आप जैसा we should not be parallel. Yes. Okay. Yes, yes, sir.
Such a case like this, there is a heavy masticatory forces.
Yes.
So why not we should give us a metal acrylic first and then afterwards?
But I don't want her to return back anytime soon, or I don't want her to cause any problem.
No failure and there will be no any problem.
You believe me, there will be no failure at all if you go thoroughly into the principles. सर मैं एक बता रहा हूँ अगर आप कल नया नया चालू करेंगे तो 10 इम्प्लांट डालेंगे तो एक कन्वेंशनल की तरह आप पर दया एहसान कुछ भी नहीं दिखाते. कन्वेंशनल कितना बुरा भी डालो आप आपको ग्रेस पीरियड देंगे कम से कम 2 साल. ये कितना भी मिडिल से डालो तीसरा दिन ही छोड़ जाएंगे. तीसरा दिन दे स्टार्ट मूविंग. ऐसा नहीं करते सर ये. दे डोंट स्पेयर यू एट ऑल. कन्वेंशनल इम्प्लांट दे स्पेयर यू. आई हैव डन सच बैड केसेस दे स्टेड फॉर 5-6 years. आफ्टर पेशेंट तो आता है बोलता है ये तो 10 साल पहले है सर अब तक तो अच्छा है. तो यू विल गेट दैट ग्रेस. You can escape the entire thing because it's 5 years, but the patient thinks it's 8 years. You can escape it. But here, within 15 days, you'll get the patient. चिल्लाता रहता है OP में. I have faced n number of failures more than anyone else in this room. Welcome. Okay. This is the best case. For sectionals, especially. If you ask me, sir, आप stress feel करते हो full mouth में नहीं तो sectionals में? I'll tell you, sectionals give me stress and adrenaline gush, and night time I'll be exhausted. Full mouth आप 5 दे तो 5 भी करता हूँ, कुछ भी नहीं होता है. Sectionals are tricky. Sectionals will fail badly. Yes. So because there is no cross-arch stabilization. Yeah. And then I'll wrap it up with Madam asked 2 prosto videos I'll show. Yes, madam, this is also as you asked to. This is just a क्या हो गया यार? नेट गया है? आ रहा है छोड़ दो आ रहा है. So this is directly on the implants, madam. No bar, nothing. The zirconium with a good cross section is itself a bar. छोड़ दे यार अभी. Yeah, so you should be in a cortical and you should be in the farthest cortical, third cortical or the farthest cortical when the patient age is less. You can be in the closest cortical or even the oven bone in this anterior mandibular region because the symphysis is the highly mineralized bone. You need not engage the floor. Except in the previous yesterday's case, only one implant I need to perforate the floor and engage. Thank you. ठीक है, तो अभी मैं आपको चीपर वे बताता हूँ। जैसे जिरकोनियम तो हमारे पास तो लैब पड़ा हुआ है, शेषु सर के पास तो बड़ा लैब पड़ा हुआ है, तो हम तो करते रहते हैं। डू यू नो द सीक्रेट? Yes, we are all dentists. Do you know the secret? How much does it cost for you to make your own zirconia crown, single unit? Prosto? क्या हो गया यार दुनिया का? Prosto is life. It's 70 rupees. 70 or 80 if you are using good blank like Sage Max Zirconia ST. आपके पास लैब है, आपके पास लैब है और एक क्राउन करने के लिए आपको पड़ेगा 75 to 85 rupees. That's why I do so much zirconia. So, but I'll show an alternate way also. Yeah, this is again with the saulabhya of this gentleman. We have got internet again. See, these are the markings which I want to highlight. These blue markings are the contact points, sir. You need only 3 points of contacts in both the quadrants. Third or fourth, 3 here, that's it. That's the functional thing. Even Malo proposed this thing first. Paulo Malo, you know him? The founder of All on 4, Paulo Malo, has always advocated 3-point contact and no teeth beyond the 6. 1, 6, 2, 6, 3, 6, 4, 6, that's it. You go for TTPHIL concept, you go for any conventional concept or any basal concept, even for the Zygoma concept, there is only one prosthetic concept, that is Paulo Malo's concept of Malo bridge. Okay. Yes, this has been done. I want to show you the contacts, that's it. So now let's see, when your friends ask for a cheaper alternative because they can't afford. Again, this one will be the last case of mine. This is a failed All on 4 case. I have operated this in Nizamabad or Hyderabad. Hyderabad or Nizamabad. So these are the 4 implants. 3 of them failed. I am not a hater of conventional implants. If they are staying, I'll let them stay. Now you should know this. This is not a Sunni-Shia conflict. This is nothing like that. If it stays, we are happy. If it doesn't stay, we will intervene then and there. That's it. So this is the only one implant that is staying. So I removed these 3. You can also see an impacted third molar here. So people ask me this question, sir, we have impacted third molar, can we remove it and immediately place double pterygoid? It's even easier. Removing the impacted third molar you will be seeing the pterygoid plate for the first time. Directly. Congratulations. So I have removed this directly into the pterygoid plate. Directly into the pterygoid plate. Double pterygoid, quad pterygoid, बीच में 4, 5, 6 ये भी है. Okay, so I'll further see. These are the failed 2-stage implants with all the costly multi-unit. See the costly golden multi-unit there. पड़ा हुआ है 3,500 का. हाँ. तो उसके बाद this was the case. This was the pre-op. These are the multi-units. I have removed, and this multi-unit I have placed just a temporary cylinder on this. This is what we call as a temporary cylinder on a multi-unit. That's enough. You need not change the multi-unit and place normal abutment. If there is a multi-unit abutment, you at least maintain that temporary cylinder is given free of cost with a multi-unit. So place the temporary cylinder, give the torque of 30 newtons, मिला दो बस हो गया. Okay, and I'll show you the latest cheaper alternatives because these are all non-welded cases, madam, which you are seeing. Now I am showing you some of the welded cases. Yeah, this is again, you think that I don't do conventional, but even now I do conventional. This patient, these implants were done by me, and he again came and asked for implants. He said, I only want those varieties. I am a slow guy. Very good. Place implants. This is a 20 mm terry-fit implant, 20 mm terry-fit implant of Norris. Okay, into the pterygoid. So we'll load it after 3 months. Okay. There is, I again say that this is no Sunni Shia conflict. Yeah, this one, I want to, see, this case again, she has no time. She is a patient from US. This tooth is missing. And this is called the bipodization. So why do we bipodize? We bipodize because stability is always there, because I placed a rough surface in my life. This is as you can see here, this is a compressive, because I want the sinus flow to stay there. I placed my Janka jigri, this is smooth, this is the compressive rough. I am praying that the sinus flow would not recede. Because rough surface, this is the advantage of rough surface, it will help your sinus not to recede. You will get a volume of bone around it always after osseointegration. Okay. So there are advantages of two-stage implants also and rough surface implants also. Yeah, this is again a welded wire in between, and this is the scan. See the scan, beautifully it will come. You need not worry about the impression. Yeah, scan bodies or the impression. Even in this case, you can't keep the scan bodies, sir. 2 implants are there, welded. So yeah, this is the 3D printed model, and we have given zirconium. Beautifully, she went back to US. So she came to me. This is again 2-stage. Okay, chhod do isko. Because we are not talking about 2-stage today, I would like to say that 2-stage implant practitioners are always safer side. We get more bad name than I used to get more good name when I was a 2-stage practitioner. But after the learning curve, when you are proficient in your placement of basal, you again you will regain the lost charm also. क्योंकि पेशेंट विल स्टार्ट, अरे ये 3 महीना मांग रहा है, ये 6 महीना मांग रहा है, ये ग्राफ्ट मांग रहा है, वो तो कुछ भी नहीं मांगता है, मेरा तो चला, आप भी चलता है, चलो बुलाते आते हैं. So this is another case, madam. So he was using this partial denture. I have done this case beautifully, and this is a pterygoid and again nasal engagement and all. So after 1 year he came for the lower, and again such deep, such nerve bypasses and zirconium. Okay, so this zirconium is again on a bar. This is the intraoral pick. Next day itself, sir. Ladies and gentlemen, this is the next day itself. And these are the zirconium crowns. Yeah, this is after welding, yeah. So I am going to show just one process video before I conclude. This is again, this is madam, I will again show you this case recently. That this is a bar cemented, madam, not welded. So this is the case. These are the implants. This is the hybrid denture, acrylic. This is the occlusion. You can make the plane of camphor is already 0. AFMP angle is again 0. Yeah, this is quadrioid, yes. So I'll, if time permits, I'll explain you about the principles of prosthodontics that you have to at least respect. This is again a case of same case, that's a cemented, this is a welded case, sir. Full mouth. Upper lower here you can see the drill, pilot drill broken in the mylohide. No one can retrieve it, sir. Chhod dijiye wahan. You don't try to retrieve it, you can't. Yeah, leave it there, proceed. So then this is the welded bar inside the mouth. This is the welded bar in the maxilla. This is the occlusal view. This is the hybrid denture. This is what we call a shell denture. This is the cheapest way to get yourself out of a full mouth implant. And believe me, within the next 5 or 6 years, the patient comes happily that they are worn off. Then you can tell them the option of zirconia. Again, you will get 70,000 from the same patient. Okay. If he is not paying you today, he will pay you tomorrow, no problem. But the engine should work. The tire should go, the engine should work. AC should work, car should be built the same. The tire should go. Now and then that tire should always go. That's the recurrent revenue that you can generate. वो तो कसना ही है उसको. ठीक है. Yeah. अरे सर जी अब इसको बोलता हूँ कि इसको कैसे चिपकाते हैं बार के ऊपर. आपको देखता हूँ यार, पर ये इसको कैसे चिपकाते बार के ऊपर. Prosto? Yes. No. Pattern resin is very hard, sir. You anytime in your lifetime have heard about denture relining? So we use relining, intraoral chair-side relining material, which is also an acrylic, but the setting temperature for the cold cure acrylic is around 70 to 80 degrees. For this it is around 35 to 40 degrees. And it is biocompatible most of the times. And जैसा आप रिलाइनिंग करते हो उसके अंदर इसको हार्ड रिलाइनिंग मटेरियल को डालते उसको ऐसा रखते हैं वो that will flow through and through the bars which you have welded, and it will set, it will be so hard like a cold cure acrylic, and there will be no monomer component left within the next week. जैसा आप जैसा सेल्फ क्यूर आरपीडी बनाते हो उसमें monomer component will seep into the oral cavity for the next 2 to 3 years, believe me. That's why heat cure is mandatory, because we are heating it to make the monomer go away, dissipate. Here we are not heating it, but the monomer is built in such a, that's why 100 ml कितना आता है सर bottle? 100 ml bottle costs you 12,000 rupees, where 100 ml of cold cure costs you कभी-कभी free भी देता है वो डिपो वाला. अरे ले जा उसको. But this will cost you 12,000 rupees, 100 ml. Yeah, so I'll show you. Yeah, you can also appreciate there's some kind of relining material you can see here. It will be completely sealed, no gap. So I started bending. सही सलामत में आ गया अभी. जिनको see the Jagoma is the hardest cortical bone with no oven component. There will be no oven bone in the zygomatic bone. There will be no trabecular pattern. Okay. So this is the left one again. See where it is coming into the palate. Now where am I bending it? Onto the occlusal surface correctly in accordance with the remaining implants. This was done by me in Visakhapatnam. Yeah. So see cases like this, 70-year-old female, you lose her within no time while doing zygomas. चेयर में रहेगी, आपके ऐसा देखता रहेगी, 5 मिनट के बाद आपको नहीं देखेगी. That's why I warn you. You have the IV cannula in place before the treatment. I advise you to keep atropine and adrenaline ready. Atropine mainly, because oculocardiac reflex is a cardiac depressant. So you will feel bradycardia. Your monitor, if it beeps, slowly administer atropine. No, it's not rocket science. Slowly, 0.6 mg atropine, slowly, not 6 mg. 0.6 mg, yes. Okay. Again, you might ask me that why are you saying that prior to the procedure you need an IV line? Because when she is having bradycardia, you can't find even a single vein. You can keep the tourniquet, you can press, you can keep the glove, no vein will be found by you because venous pressure collapses before the arterial pressure. You will not able to insert your IV cannula then. So prior to the procedure itself, you insert an IV cannula. Okay. Then you can give this directly, atropine. Okay. The last thing. Previously I used to do lot of Jagoma implants. You won't believe me, I would do such lot cases, but with the advent of corticoids, everything is gone. So this is again, ladies and gentlemen, zirconium bridge which surprised many of my colleagues like nothing else. That's a zirconium bar. Sir, the zirconium bar will never break if the cross section is respected. Even the metal framework breaks if you are not respecting the cross section of 3 square mm. You saw the metal ceramic bridges breaking, na? You should have at least 3 square mm, 12 square mm, 3 into 4, 4 times, yes. So this is the bar, zirconia sitting perfectly on the implants. So you snap it. And then I am scanning with a intraoral scanner. You can see beautiful zirconium bar. On the pink, the white looks really good, yes. So these are the upper teeth, this is the lower teeth. And then exogas substructure anatomic wax up. This is the zirconia. That's it. Yeah, ladies and gentlemen, that's it. If you got any, yeah, thank you. Oh, yeah, I appreciate that. Yeah. So I should not cross infect some others. So I am rubbing it, so it ajib se sound aa raha hai. So yeah. Any questions? Yeah. It's very easy to master basal implantology, sir. But you should prepare for failures. Yeah, and you should do them at low cost in the beginning. That's true, sir. What Rajesh Sharma sir told yesterday is a fact. You do it at very nominal cost, so that the patient will not. Even I have done some Fulmos for free. They failed. They came, I replaced. That's the best way to learn, sir. Yes, Jafar Awad, sir. Doctor, any courses on this topic, cortical basal with practical? हर रोज लोग ऐसे पूछ रहे हैं मैसेज करके कुछ कोर्सेस है जैसे नहीं सर ये तो आपका नहीं है आपका नहीं खुला हुआ अभी जैसे सर भी पंजाब से आए थे जैसे मैं बोला था यहाँ पे कोर्स चल रहा है तो थैंक यू सर हैव यू फाउंड इट वर्थ बट यू विल फाइंड इट व्हेन यू स्टार्ट प्रैक्टिसिंग सर बट भूल जाएंगे नहीं तो सही में बोल रहा हूँ सर ये सर हाँ तो मैं देखता हूँ सर आपके पास आता हूँ अभी थैंक यू लेडीज एंड जेंटलमैन एनी अदर क्वेश्चन फ्रॉम द प्रोस्टो गाइस अरे सब कुछ प्रोस्टो में है you are going to make good money if you are ready for it but okay no problem
कैसे जाती करना होगा
थैंक यू
नेवी फ्लोर बहुत पास में
सर इसको निकाल दीजिए
यहाँ
डायरेक्ट
पे
हाँ सीधा
दो जाएंगे
दो जाएंगे सर घुस जाएंगे तो कुछ प्रॉब्लम
और
है
मैं कुछ पूछना है कि नेवी फ्लोर पे ये लेंथ तो बहुत कम है
सर आप 18 में मिल जाएगी
यहाँ इंगेज करना है
नहीं सर बिल्कुल वाइट लाइन है आपको डिप मालूम होगा आपको कभी भी वो इम्प्लांट का उस पे जो मार्किंग्स है उसको देखता रहना पड़ेगा ताकि डिप जहाँ पे आए यू शुड कैलकुलेट इट यू आर जस्ट नॉट ड्रिलिंग सर यू आर कैलकुलेटिंग ऑल द टाइम वेयर द डिप इज एंड द डिप शुड बी रेस्पेक्टेड
यहाँ नेजल फ्लोर में इंगेज कर सकते हैं व्हाइट
हाँ 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 सर बिल्कुल अच्छा केस है इसको निकाल देंगे
यहाँ दो निकाल दें और इधर
दो नहीं सर आप जैसा है यार Again find a venous anastomosis is there, you will find serious bleeding coming into the sinus and then into your nose. So first it fills up the sinus from the middle meters, it comes and it will come out. You will think that मैंने nasal डाल दिया तो जरा नहीं आता है शर्ट भी पूरा कलर बदल जाती है तो रोकने के लिए आपको करना पड़ेगा हेड अप और जरा उसको सांस मुंह से लेने के लिए बोलिए क्लॉट फॉर्म होगा हीमोसाइनस होगा क्लॉट इन द साइनस होगा इट विल रिजॉल्व बाय इटसेल्फ नेचर नहीं नहीं
सर ड्यूरिंग द प्रोसीजर तभी बंद हो जाएगा ब्लीडिंग हो जाएगा
ट्रानेक्सा 500
एटाम्प्लेट
Tranexta 500 best sir.